Chris, I loved seeing you last night. I had fun on the town hall or whatever we did.
You know, it's so funny. I was going to say that. So first of all, hi, welcome everyone. But if you missed it, please watch the recap. What Liz is talking about is all of the lead and national advocates were together. We did a big talk on stigma around sharing your story, and not just like on a national or international platform, but to friends, to family, to coworkers. But it was so good because it was all of us. It was so good seeing Liz. And I was going to literally start with that. I was like, oh my God, it feels like I saw you just recently. So
I know, it was so fun to see everyone and to just chat and to share experiences. And it's so interesting how something like stigma, where we all feel the same way, right? Which is like, we all want to reduce stigma and we all want to make a difference around the stigma with OCD and mental health. The more we talk about it, we all just learn so much by each individual story. And what I always realize is, again, this is just another thing with OCD and mental health where it is so individualized, right? And it impacts different things, impact us in so many different ways. We could hear one story and be like, that was terrible. And for some people, it's like, oh, it's not a big deal. That's terrible. Where this situation was actually what was terrible for me. And so just always a reminder that we all have different experiences around every single topic. And I love getting to hear the perspectives from us, but also all the viewers. It's so fun when we get to talk with y'all and chat with y'all live.
I think that was what's cool is just so many people in the chat just sharing their experiences, and some people had good experiences, some people were offering support to others, and then some people had similar stuff, just similar concerns about opening up and sharing the story. And I always think about it like one of the things that I hope, you know, your legacy, my legacy, and all of us is that there gets to be a day where people are like, oh, there's no stigma for me. I just share that I have OCD, and people are like, cool, totally understand that. How are you doing? Are you
And
okay?
that they actually get it and get what it is, right? Because like that's the big piece for me is I feel like you probably feel this way, Chris, is like for both of us, there were so many years where people didn't even know the acronym. And now most people know the acronym, but they know it in the wrong way.
I know exactly. Well, one of the things that I said last night that it has kind of always stuck with me is like for some reason, kind of society in general has been able to define OCD for us. Like our community hasn't defined it. So when I talk, if I was to go up to 10 people on the street and ask them, what is OCD? Some might know obsessive compulsive disorder. Some might not even know what that whole term means and just think of it as like, oh, yeah, isn't that where you wash your hands or keep things organized? So it's definitely one of those things where we got work to do. And I can't wait till the day that we as a community can define it and people can understand. And I have hope. I mean, it was way before our times, but my mom's talked to me about everything that went on with cancer and how people wouldn't even say the word and the stigma. And now, I mean, people are constantly donating. There's research, people offer support. So if we can get that to the OCD community one day, I think all of us would have better research, better access, and I think just a better sense of belonging while we're going through it.
Totally. It's and the last thing I want to say is everything is a process, you know, and I think the one thing we can say is like it is getting so much better, which is so exciting. And I just want to say that because I think the work that IOCDF does, the work that so many of us do, it's often like not illustrated. And instead we focus so much on like all the work that needs to be done or the person that got this wrong. And what I want to just say is to watch the difference in the way we talk about OCD, mental health, the understanding of it, or the way you see this young generation being willing to be open and share. It is so cool. And that is because of the incredible work of the foundation, of so many advocates, and of all of you. So I'm excited to be here. So let's hop in.
Yes.
Great to see everyone. Please tell us where you're joining from. Put it in the pane. Make sure you put comments, questions you have for today so that we can answer it. What are we doing here? So today, this is Ask the Expert. So Chris and I, this is our bi-monthly series where we hop on and we just do our best to answer questions that are typically around or about OCD, mental health, stigma, anxiety disorders, or related disorders. And please remember, when we're answering these questions, we're doing our best to share our professional and personal perspective, but we are not acting as your clinician. It's really important if you have specific clinical questions for yourself to defer to your own clinician. And of course, the foundation or these webinars or Chris or myself are not crisis hotlines. If you're feeling like you're in crisis, you're suicidal or unsafe, we want you to call 911, go to your local emergency room, or call the suicide prevention line, which in the US, it's 1-800-273-8255. But of course, if you are international, please contact your own local emergency services. So I have so many announcements I could probably go into, but y'all know I always skip half of them. But please make sure you go to iocdf.org/peace of mind. This is where you can put comments, questions, And more importantly, you can see all of the upcoming things that we're doing. So we saw a lot of you last night for our Tuesday community conversation live streams that are focused on either community conversations with Ethan or of course town halls. And then on Wednesdays, we do these webinars that are either Ask the Experts, Lunch and Learns, where we bring in experts and to have a specific topic, or the Research Roundtable. So that's who we are. That's what we do. Please keep engaging. We're so grateful for the community. We have so many pre-submitted questions, and let me give a little plug. I actually, Chris and I have been saying for a long time that for the pre-submitted questions, we're going to start going through them and answering them. And I actually spent about 20 minutes last week doing that. And so I did get to go through some of the questions and I answered them. And so that will be posted on YouTube. So Skyla will be posting these YouTube, we'll probably call it Ask the Expert responses. And it'll be like response number 1 or number 2, but it'll be a 20-minute or so, maybe an hour, who knows, however long we have, but it'll be a segment where really it's focused on these questions that we don't get to, that we do our best to answer so that you can have them there, because we don't want you to think we're forgetting about you. And yes,
we got to come up with a way cuter name than Ask the Experts responses. So we need to, that was a little workshopping. We need to troubleshoot. We'll come up with something cute.
You mean that's not good? But Chris still loves me. He's just, that's just his way of giving sweet feedback.
You look so pretty today. I was going to tell you that. You always look pretty, but you look so pretty today. I like your outfit.
I was going to ask if you got your hair cut.
No, but what happens is, I know, because when I took a shower yesterday and not today. So when I don't shower, I shower every other day. So if you get me on the every other day, my hair looks better. So it's either clean or cute. We can't have both.
Yes. That's great. So yeah. Hi, everyone. Lizzie, thank you. You can also dial 988 now in the US if you're feeling unsafe or suicidal, which is so awesome for us to have a specific response line that we don't have to go through 911. All right, Chris, do you want me to start with pre-submitted questions? Is that?
Yeah, and for all the people in the chat, I know we already got a question from Caitlin, but if you have any questions live, please put in the chat, whatever social media platform you are utilizing to watch us, and we'll answer those questions as well.
Awesome. So let's get started. Our first question is do you have any advice for recovery from contamination OCD with regards to COVID-19? The uncertainty is too much for me to accept since COVID is a real ongoing issue and long COVID freaks me out. I feel like I'm the only person still trying to avoid COVID, and it's very isolating. I'm also afraid therapy won't help me since I'm not willing to go all the way back to life as it was before the pandemic, and I will quickly hit a wall where I'm not able to do the exposure. This is such a good question. And I want to just caveat it because of course we can answer anything concisely because I get too excited. But I want us to talk, Chris, about 2 things. I want you to answer this question, but then I also want us to focus a little bit on how this question applies to all OCD treatment and the pitfalls and kind of misconceptions of uncertainty. So I really want us to focus a lot on, like, do you have to be okay with getting COVID? Do you have to be okay with the thought of having long haul COVID? Do you have to accept it as truth or as certainty compared to what does treatment actually look like?
Yeah, what I always try to do first and foremost is validate. Obviously, it sounds like you're in a lot of pain. The person that asked the question, I always kind of, my heart goes out, and I think that's why Liz and I do what we do. Is we both had our moments we were talking about last night, where we're on the ground, lowest moments, and so we validate it. The way that I like to look at it, when Liz talks about uncertainty, I think when people think of that, they think of, okay, and we're doing a talk at the virtual conference about this, that in order to accept uncertainty, in order to tolerate that, in order to kind of, live your life and get out of the house, you have to be okay with getting long haul COVID and the worst symptoms ever. And that's not what we're really asking here, because nobody would do that. I know if my treatment was like, be okay with the fact that you're going to kill your grandma and your sister, that wouldn't have come to. What it is we're changing our relationship with these thoughts and these feelings. And so, yes, I can't promise you, unfortunately, as a clinician, that if you leave the house, you won't get COVID and you won't get long haul COVID. There is a level of uncertainty there. What we are asking you in the treatment, though, is to say, look, there are certain things that Liz and I do to take precautions on our everyday way of life. So does everybody else. And there hits a point where we no longer can do anymore. Like there's a certain level of safety that we can ensure. And then we have a decision to make. That's how I like to think about it with my own treatment, is we have a decision to make. We can say, look, I don't want to tolerate uncertainty. I don't think I'm safe enough. I'm going to resort to going back in the house. And absolutely, we all have that choice. But as somebody who was housebound for 3 years, Liz can speak to her own story. That isn't a way of living either. That's a guarantee that your life is absolutely miserable. The difference is there isn't 100% guarantee that all the fears that OCD yells at you about is going to come true. And so what we do is we do our best. And then there gets to a point where we have to say, look, I can't guarantee for the rest of my life that if I go out and live it, whether it's COVID, whether it's hitting somebody with your car, whether it's accidentally pushing someone in the street, whatever your OCD is around, there gets to a point where we can no longer get that guarantee. And that's when we ask to tolerate the uncertainty. It's really saying, look, I've done my part. There's nothing left to do. I have to be okay with the fact that I'm not going to know everything. So that's how I like to think about it with this. My heart goes out to you because right now, because of the fear that your brain's created, it sounds like your life is really, really small and isolated, which is super scary too.
Totally, right? So I want us to lean into the two things that Chris just talked about. And Skyla, if you could post these as comments, it would be great. So number one, treatment and uncertainty does not mean that we have to accept our worst case scenarios or our fears as truth. So if we can just post that, you can just post, Skyla, we do not have to accept our fears as truth. In fact, what we're actually teaching you to do is to just live your life without letting the fears dictate your life. So, I think one of the questions, part of that question was, do you have, like, I don't feel like I can go back to the way life was before COVID. Most people haven't, right? Most of us are not going all the way back to a life where we don't think about COVID at all, or to where we don't have COVID on our radar like we did 3 years ago, because guess what? That's not reality for us anymore. COVID is still here. COVID is something we still might take precautions on. One of my good friends tested positive recently. Like, I'm not going to hang out with her tonight. I'm not going to go spend time with her because it wouldn't make sense, right? That's not a safe practice. It's not something that would be recommended. But do I need to be able to live my life and follow CDC guidelines versus following OCD guidelines? Yes, right? And that's really critical. That's a piece I want us to be thinking about, is that treatment doesn't mean we're taking or engaging in risky behavior. And in fact, if a clinician is ever asking you to do something that you're like, I wouldn't do this OCD or not, my friends or family wouldn't do this, you shouldn't be being asked to do it, right? Hierarchies, exposures, they should be things that are values-based. They should be things that are, sometimes they might seem bizarre, but most people, not most, all people without OCD should still be willing to do it, including the provider, right? So that's number one. Number two, the goal of treatment is that we get you back to living life. I think a lot of times we think, oh, OCD treatment means we just do these like crazy exposures, and that's really what ERP means. And uncertainty and pushing uncertainty means you have to like go all the way and you have to think these disgusting, horrible things. And I think Chris and I would tell you, absolutely not. OCD treatment is, let's get you back to functioning. Let's get you back to life. Let's give you freedom. And let's do it in a way that OCD doesn't dictate it for you, right? And instead you get to make your own choices. Next question is, what is your advice for how long and how frequent to continue OCD behavioral therapy as an adult, specifically ERP with a trained clinician?
Yeah, if I understand the question correctly, the way that I like to think about it is, people ask me that all the time. They'll say, how long is treatment going to be? All of our treatment's different. If you go to a residential, the Houston McLean program that Liz runs, your treatment may be shorter than what mine was. Unfortunately, when I was at my sickest, first of all, I could not have even traveled. That was way too hard. And all the intensive outpatients and partial hospitals had a year and a half booked out, and I couldn't go. I just attempted suicide, was kind of on that watch. So I needed something quick. My treatment was about 2 years, of every week treatment. And then obviously utilizing the tools after. So once you get to a point, the way that I like to look at it is, once you get to a point that with that clinician, you've really learned and understand what's going on in your head, you understand the treatment, you get it. I always tell people, like, my goal in that psychoeducation is to teach you how OCD speaks to you and how we get fooled by the way it speaks to you. And once you really understand that and why the treatment is so useful, then when you work with your clinician and you get to the point where you've crossed off most of the things on your hierarchy, you're doing well, you're re-engaging in life, you can definitely kind of pace those sessions out less and less and less, and more infrequently. then eventually you might get to a point where you don't see your clinician. However, and this is something Liz and I talk about all the time, the way that I tell my clients that I know it's time for us to kind of not have anything on the books, they can always reach out, is when they're living that ERP lifestyle. So what does that mean? An example is when a client will say, hey, I have 2 roads to get to my work. They're about the same distance. This one goes by a school. It kind of triggers the OCD. So I deliberately go that way. For me, I know for a lot of times it was deliberately spending time with my grandma and my sister who I had OCD around harm thoughts with, or I would order food where I'd have to use my hands because I knew the grease would bother me. And so you start to just kind of live that lifestyle where it no longer feels like you're doing therapy, or more so just living life, and therapy happens to happen quicker and quicker until you barely realize you're doing it.
That's right, 100%. I have a loved one with responsibility and ethics related OCD. How do I make sure I don't accommodate since I can't see or read what's on their mind?
Yeah, that is a really tough thing, is because, when somebody's OCD is much more internal, you might not understand like how you're accommodating. But what I'll say is a couple things come to mind. First of all, reassurance seeking isn't always reassurance seeking. Sometimes it's confessing. And the difference is they may not be asking for a specific response from you. So it seems a little less harmless. Instead, they're kind of just narrating their thoughts, or they're externalizing what's going on in their head to kind of see your reaction. However, let's say, for instance, your loved one is absolutely not doing any kind of reassurance seeking. Let's say that they're not asking you questions. Then you might want to see if there's any enabling going on. Is there certain rooms you don't go into because of their OCD? Are there trips you don't take? Are you the one that's always driving? Things like that. Then let's say none of that's occurring either. I would say lastly, one way that you can see that there might be something going on is when clients are giving into mental compulsions. Often it's where they're not even paying attention in the conversation. Like maybe you're out to lunch and you can tell that they're half there and they're more in their head. That would be kind of when you could recognize like, hey, I don't see the OCD. They're not asking me reassurance questions, but I don't even think they're really present. So checking in with them and saying, hey, are you focused on me? Are you engaging in mental compulsions? And if they confess to you, yeah, I'm doing some mental compulsions. Okay, why don't you practice being here in the present, utilizing the tools you're getting in therapy, and engage with me? So there's different layers people may be doing. And lastly, if the person will bring you into a therapy session, or at least open up to you what their OCD is, that might also help you figure out what you could be potentially doing to engage with the OCD.
Totally. I'm going to add in here, my biggest thing is live your life, right? So if we are living our life the way we would want to live our life, then we're probably not accommodating or triggering, at least not intentionally. But does that mean when we just live life, we might accommodate on occasions without knowing, or we might trigger someone without knowing? Yeah, probably, but that's okay. I actually don't want you to get too focused around, am I accommodating? Am I enabling? Am I triggering them? Because we don't want it one way or the other, right? We don't want someone to be so worried about triggering that they don't live their life, or so worried about accommodating that they are like purposely triggering the person either, right? It's not, because that's not your job. Your job isn't to intentionally have them face their OCD. That's their job. Your job is to live your life and to know that their OCD will respond in lots of different ways to that, but that's really the healthiest way to go about it. This is a great question. And Chris, I think it'll relate to you a little bit in your treatment. But for a 6-year-old with OCD hoarding tendencies, with high distress at even throwing away cardboard boxes, what is a good plan to support her as we throw away everything in our house? Oh, sorry, never mind. I thought this was a question around OCD with toxic mold. But to support her as we throw away everything in our house due to toxic mold. This is per the doctor's instructions, and significant illness has resulted from the house.
Yeah, so toxic mold was one of my biggest triggers, probably triggered the onset of it. I will say I did engage in hoarding. My grandfather, my mom's dad, was an extreme hoarder to the point that you couldn't go in certain areas of the house. When I work, I think a lot of times people typically, when people think of a hoarder, it's an elderly woman, potentially an elderly man, but kids hoard all the time. I worked with a 12-year-old hoarder. So what I like to do is definitely the first thing you want to do is get them into treatment with somebody who, really works and specializes in working with younger kids or children with hoarding. And what I would say with that is I think everybody thinks hoarding is just like going through and throwing stuff away. But you have to remember, by doing that, the client themselves, or in your case, your 6-year-old, isn't learning anything new. They're just going to keep hoarding and keep hoarding and keep hoarding. So the treatment is really helping them understand, like, these items give you feeling, safety. Sometimes it's a fear, if I throw this away, I'll need it in the future. Sometimes the item is associated with a positive memory. And so what I've done with clients is really get them to understand like how that kind of hoarding trap happens, that kind of connection with the item and a belief, and sort of being able to separate and explain like, hey, this is just a cardboard box, or this is a napkin you got on a trip you liked. Did you take pictures? Is there other things you can refer to besides that napkin? But I really help the client understand like this item comes into your house. Why do you need to keep it? Should you get rid of it? Why should you get rid of it? Okay, if you keep it, why are you keeping it? Just getting them to understand further what they're doing. The other thing I find that helps a lot, especially for kids, is if they're keeping items like stuffed animals or clothes or things like that, is explain to them that there's kids out there that might really, really find it valuable if they were to give it away if they don't need it anymore. So that really helped my kid client that I worked with recently, knowing that the stuff he was giving away was going to go with someone else. But going back to the main point, it's definitely something you want to get an intervention with, because if there's mold happening in your house and it's pretty severe. Last thing I'll say is I know in our counties in Southern California, they actually have people, they're called hoarding task forces in different cities, and they're people trained that work with individuals that hoards. They won't just come in and clean up and be reckless. They'll really kind of work with you, have the person be involved so they're learning. So if you can team up with that and a therapist, so your child starts to learn what they're doing and why that it's causing problems in the house.
100%. And the next part of that question is, as a parent with moral scrupulosity OCD, how much information is helpful to explain to a 6-year-old in reality and not according to my OCD lens? How do I honor her grief and let her have closure and say goodbye to things, but also not accommodate all her OCD tendencies or my own moral scrupulosity and not disclosing everything?
Yeah, I would say the biggest thing, and maybe you could expand on this, but the first thing that comes to mind is like whenever I work with a client that's a parent with OCD and they have a child that is starting to show OCD symptoms, kids learn from modeling. I mean, especially at 6 years old, they're going to be looking up to you and seeing what you're choosing to do. And so make it a team effort. I was working with two two boys, both had OCD in a family, and their dad also had OCD, and they weren't doing as well in treatment as I had hoped because they really wanted to get better and they were understanding. And then I found out that the dad was kind of giving into his OCD a lot. And so we really worked on bringing in the dad, making it kind of family affair. And it helped really with understanding as well as them pushing through and doing well in treatment. So I would say that you can have both. I mean, if a client comes in with hoarding or any subtype in distress, I'm never going to sit there and be like, snap out of it. It's just OCD. I validate their experience. You can validate, what your child is going through, and you can also explain how that behavior is causing a lot of distress in the home, and having a clinician, really kind of help her or them understand it, so that it doesn't feel like they're just throwing away these valuable things. So really educating them, but doing it as a team.
Yeah, and I would just hop in. The only thing I would add is just make sure you're engaging in your own treatment, right? We see this often where parents are often living with their own anxiety or their own OCD and also working with their kid, and you deserve to get a break from your illness as well. So don't just become their provider, right? I want you to stay their parent. I want your child to have their own provider, but I also want you to have your own provider so that you're not seeing your diagnosis also impact theirs, because that can be a spiral.
Well
Next
said.
question is, my 14-year-old son has recently confided that he has been having intrusive thoughts, and I'm researching and learning a lot about it. Is there a virtual teen support group?
Yeah. So, for instance, I run one in California Wednesday nights from 6 to 8. So it's tonight. But there are definitely different groups out there. I do always recommend going to the IOCDF's Find Help website. I know that Liz, obviously, if you're in Houston, you're getting treatment with her. I'm sure she has support groups. So we all in treatment recognize the absolute necessity for support groups. They're so helpful. So what I would suggest is go to the iocdf.org/find-help. And what you can do is put in the zip code of where you live, or since it's virtual, can put in the state. And then what you do is because I always help people find this through OCD SoCal, then what you're going to do is you're going to go and put under your search, put support groups, and that's going to have them pop up. And then you could find ones for teens. I think it's great because a lot of times like teens are in this period where they want to fit in, they don't want to feel alone. And so support groups really bring on camaraderie. So I would definitely go to the iocdf.org/find-help search function so you can find a support group in your area. Last thing I'll say is if there isn't one in your area, because sometimes I get that, I would say virtual, there's probably one in your state, but if there isn't, one thing you could always do is talk to your child's clinician, your 14-year-old son's clinician, and see if they'd be willing to start a support group, or reaching out to a local affiliate, see if they'd be willing, or sometimes starting a peer one yourself. My mom started a family and loved one support group that we do every second Saturday, and Liz has been on it. We're up to 80 to 90 families per month, and that was started from my mom 8 years ago. So don't count yourself out if there isn't one in your area.
Totally. Next question is for you, Chris. As the parent of a young adult who suffers with BDD and OCD, I'm struggling to find content on how to help them. Is there overlapping treatment that can help them?
Yeah, so I recently did a talk at the in-person conference about the difference between BDD and OCD treatment, because there are some differences. Sometimes people think of BDD as like OCD about appearance, but there's so much more than that. In fact, a lot of the research that you can find, so Skyla, maybe in the chat, so you can put, the IOCF actually has a BDD specific website. And on there, there's some really good research that talks about how individuals with BDD, when they look in the mirror or when they look at other faces or even inanimate objects, they see things differently than somebody without BDD. There's also, if you go to, I think it's, if you search, I'm going to have to find a link, but it's, I think it's like Science Today or something like that. But there's a video of an Australian study. So if you search in individuals with BDD see their face differently on YouTube, and I'll try to remember next live stream, but they actually show some of the studies they've done where they put people with BDD in this kind of equipment where it tracks their eyes, and somebody with BDD sees themselves differently. So there's certain things with BDD that you have to address that you wouldn't address with OCD. The good thing is there's a lot of similarities in the treatment. And I would say, I always joke around, it's like knowing Spain Spanish and Mexican, like Spanish as you speak in Mexico. Like there's going to be a lot of crossover. Yeah. So if you can find a clinician that treats both, that's really good. And then if you go to YouTube, youtube.com/IOCDF, there's actually a whole BDD playlist, and it's all different videos of people with BDD, treatment providers, etc. So there's definitely treatment for both. A lot of clinicians can treat both, and there's a lot of good IOCDF resources.
100%. All right, Chris, I'm going to switch off and let you answer some and give you a breather, or ask some.
Yeah, so I'll let you start with this one. So Caitlin at 12:06 your time, Skyla says, how do you deal with OCD when you use your compulsions to find relief? So from ordering and arranging, and you like, the question cut off, and you like being that. I believe I saw that they said that down below that they have OCPD as well, but I don't want to put words in their mouth. But what I was going to, oh yeah, they think they have OCPD too. So I would say the question, Liz, is like, sometimes people may use their compulsions as a relief. And how does somebody deal with that if they're finding that some of their compulsions actually give them relief, or if they also have OCPD, actually have them enjoy those compulsions?
Totally. I actually just did a social media post on this where I talked a lot about how organization is not OCD, because organization often brings us pleasure. However, there could be times where you're organizing or doing things for OCD reasons, right? If I don't put this in a place, something bad might happen, and that's OCD compared to I just like it that way. So the first thing I want you to think about is, what is the function of the behavior? If the function of the behavior is to address a fear or an intrusive thought, it's probably OCD. If you feel like you have to do the thought, have to do the compulsion, it's probably OCD. Compulsions often do bring us relief. Right? That is why people get pulled into the OCD trap, is that the compulsion, at least at the beginning when we do it, the compulsion does make us feel better, right? We do get some relief. What we know is that the relief is temporary, right? Whether it's reassurance or whatever it might be, we do feel better, which is why we ask it, but it doesn't last, right? It's not long-term relief. And so then we get stuck in the cycle. But OCD pulls us in because the compulsions do work to a degree, right? If you have a fear of being clean and you're washing your hands, like, you are going to feel a little bit better, but sometimes you get more stuck and you feel worse. If, however, the behaviors are much more focused on personality and I don't want to say rigidity as much as saying like a preference, right? So like I always wash my hands before my meals because that's just what I do in my family. And like, that's to me how you eat a meal, is you wash your hands first, but there's not rules and rigidity around it. So for example, I might wash my hands, but be willing to touch my phone after. compared to I can't touch my phone because then my hands are contaminated. If I'm contaminated, someone's going to get sick. It's like one's more OCD, one might be a preference or a choice or a characteristic. And so that's what I would want to think a lot about is if the behaviors actually make you feel good, bring you some joy and pleasure in just doing them, whether it's ordering and arranging, organizing, cleaning, it's probably not OCD. And that's more of a preference. Could be OCPD, could be characteristic, whatever you want to call it and however it's identified. But again, OCD, if it's unwanted intrusive thoughts and you're doing the behaviors to address the thought or to get rid of the fear, then it's OCD.
Well said. Another question I think you'd be good for at 12:21. It's from Lizzie. It's more of a statement, but I feel like you could definitely validate this for Lizzie. It says, living your life with and functioning with OCD is very depressing for me. I push myself and then feel guilty for having to work so hard to live my life.
Yeah, I want to approach this and talk a little bit about it. I want to address it because I think this is really important, Lizzie. So the first thing I want to say is, of course it is, right? Our goal is not functioning with OCD. Our goal is freedom from OCD. And I think a lot of times when we're not in treatment, many of us can have high levels of OCD and still function enough, right? We're white knuckling and it's kind of miserable functioning. And even we hear this with ERP where patients will say things like, oh, I'm doing the ERP, but I hate every minute of it. Most of us aren't going to like doing ERP. Most people don't like facing their fears and feeling uncomfortable, but it shouldn't continuously feel like there's this dread and this misery, because it should be getting you to a place where you can live by values and have freedom. So there should be this piece of, while it's hard, it should make total sense. And living life should not be really, really hard. And it shouldn't be like we're just pushing ourselves to do these things, but all we're getting to is functioning. Because if that's where you're at, I'm going to push that you're actually probably kind of white knuckling. Right? If we are living life where it's like, well, I have to do all these things, but then we're also having to give in or we're giving into all of our OCD, it is totally miserable because it is exhausting, it's draining, and you're just trying to survive and function and keep up. What we want you to do is to be able to have freedom where you can engage in life and OCD is not playing a role, right? OCD is not there. It's not dictating anything. And that's what treatment's all about. So I want you to talk about that in treatment. I want you to do values-based exposures. And I really want us to know that the goal is not functioning with OCD. The goal is freedom from OCD.
Well said. I have another question for you, but I'm going to answer Phyllis's real quick at 12:08. So Phyllis asks, is there any new research in the area of treatment and medication for body dysmorphic disorder? I was talking to Skyla on the back end. So at the conference every year, there's actually posters where they put for some of the research that they've been doing. And I saw 2 different research studies that were done on BDD. So what I would suggest is to email the IOCDF. So that's info@iocdf.org, and see if you can get in contact with the researchers that were researching the new stuff on BDD, or potentially if the IOCDF has the information, they could give it to you directly. The other thing I'll say about the medication component, I know that at the conference there was also oh my God, it's slipping my mind the name of it.
A SIG?
No, there was the SIG. So there's special
The research poster symposium.
Yeah, but the company Biohaven, thank you. My mind finally came to it. Biohaven is researching a new medication for OCD, and I know that's OCD, but it's an adjunct medication that works on glutamate instead of like serotonin, et cetera. It'll be an adjunct medication. They're still in the early parts, but they had a booth at the IOCDF, and maybe you can also, when you email the IOCDF, ask about that. I know it's not BDD specific, but typically the medications for OCD also work for BDD at the same dosage. So those would be some good questions to ask. I was able to get information because I was there, but if you weren't able to be at the conference, that. The next question for you, Liz, is from Gentile at 12:08, and it says, I did ERP for some time. Now I'm cured from OCD. I'm going to take it as like living the ERP lifestyle, so it's not impacting them. What are the next steps? So I think that's important because obviously I always want to say new mommy, but I don't know if you're really a new mommy because you had a child before. So you're a second new mommy.
I don't know the term. Still I am a new mom. Yeah. I'll take it. It feels new.
But I think that's one of the things that you've done so well. Obviously, all of us advocates is kind of like, so how did you navigate for those that are watching that are like, look, I'm doing really good on ERP. I'm about to get back into life. How would you say the next steps are?
Yeah, first of all, I love this. Congrats. It's so exciting. And it's about just redefining and understanding who you are, right? Your next steps are living life. figuring out what you love, all the things and experiences you didn't get to have because of OCD, start having them, right? I always say, we talk a lot about this, that a lot of us with OCD don't have a lot of hobbies because it was like, well, I didn't have time for hobbies, or I didn't really enjoy stuff, where now it's like, okay, so what are hobbies? Like, let me try new things. Let me figure out what I enjoy and what I don't. I know for me, part of living life when my OCD is really well managed, that is exciting for me, is slowing down. So I'm really bad at slowing down or reading or doing these sedentary activities, which I enjoy. I'm not good at them because that's when my OCD used to be kind of the loudest, is when I got quiet. And so I enjoy taking a bath or getting quiet or reading a book, right? And so it's like, just to start to think about what are the things you want to do. But the next steps are living your life, engaging in life, career, work, school, relationships, friends, family, hobbies, you name it, and moving forward. And what I talk a lot about is this thought process of ERP as a lifestyle, right? It doesn't mean we've done ERP, we never have to do it again, but it doesn't have to feel like treatment. It doesn't have to feel like daunting. It's just, it feels like life, right? As you live life, you're going to be exposed to things. You can't never do an exposure again, because living our life is opportunities that exposures will pop up.
I like this question from Summer at 1216. Maybe you could start and I could jump in a little bit. Chris and Liz, your cases of OCD were severe like mine. Could you describe how this felt?
Yeah, I mean, it felt exhausting. It felt, at the time when I was first really struggling, there wasn't effective treatment that I was having. I couldn't get access to it. And I continued to hit a lot of roadblocks. And it was just, it really increased the hopelessness, and not feeling like I could get better. And it felt like I was imprisoned by OCD. You were constantly, I always talk about, like, I felt like the only time I had a break or peace was when I was asleep, which was rare. And otherwise things were a living nightmare. This illness is not easy. It's not fun. It's exhausting. It's draining, and it's debilitating. And that's what it was for me at the time. What I will also say is that treatment gave me a chance at having my life back and being able to have freedom and do the things that I do now, which includes being able to be present, which is a huge gift. The biggest gift really you can offer anyone is peace and presence. I always think about that when the Catholic Church offers peace, right? And you shake people's hands and you say, peace be with you. That's really the greatest gift we could ever give anyone, is the gift of peace, right? It's the greatest gift we can receive, is to be at peace. And I'm hoping that with treatment, we can help everybody get there, and that you can be at peace with your thoughts, and they can be thoughts and not be triggers. And that is possible no matter how severe your OCD is.
Yeah, what I want to say really quick, Summer. I mean, I think the thing when I look back, what I'm most always sad about getting severe OCD is, like, I was such a happy person. My senior year, I was captain. I played multiple sports. I was captain, played varsity. I had a lot of friends. I was super excited about going into film school after high school. I got to film school, was working on sets, doing the things I loved. And then, OCD was always there. But when it became severe, it literally was like somebody taking away everything from me, like pulling out my school, pulling out my friends, family relationships. I'm half Greek. And, if anybody saw my my big fat Greek wedding, like, family is everything for my culture. And not talking to my mom, who, if anybody knows, my mom and I were extremely close, but I didn't talk to her for years. I mean, I just completely isolated, and being alone, and 16 hours a day of compulsions, having no relief, just constantly being in my head and just wanting it to be over. And so it's terrible. And that's why we do this work, Liz and I, is because we can remember what it was like to live in that moment and how low it was. And my heart breaks for everyone struggling with it. And then what I'll end with is what Liz said. When I got into treatment, I made it the most important thing in my life. I was hyper focused on doing the treatment to get better. And it was a process. There were some ups and downs, but I'm here today, and Liz is here because of the treatment. So nobody ever give up hope. We're going to be biased with this answer, but I'll give it to you anyways. It's at 1217. I like the term OCD warrior. Chaitanya asked, do you think an OCD warrior who overcome it has an advantage to be good, like a good psychologist, therapist, etc.? So we're a little biased, but
maybe not, right? No, absolutely, right? I mean, I think about it. There's no one that enters the mental health field for money. We enter the mental health field because of passion, because of interest, because often we're called, right? We're called to this level of service and to being able to help other people. And what I believe is there's really no greater gift in life than being able to help others and to be able to give back. And I think when you've had personal pain or experience and you can turn that into opportunities to give back, it absolutely puts you at an advantage. I think that our empathy level is so much higher than people. I find that a lot with some of my clinicians. I'll hear, this, I'll have to sometimes be like, hey, let's remember empathy and let's talk about this. Let's talk about how that person's feeling. For those of us with OCD, we're less likely to struggle with empathy because we understand it. We understand how it feels. We may not understand your OCD and your symptoms, of course, but we do know the pain and in a different way, in our own way, but it's there. So I think absolutely. The caveat to that is please make sure you've done your own work, and I will say that all the time is that there are amazing clinicians who live with OCD, but there are also clinicians who, or coaches or people doing different work that are not yet in a place of recovery in which it's hard to be able to help other people if we haven't helped ourselves first.
Well said. I'll say one thing that comes to mind is when I've been in kind of consult groups for therapists that don't have OCD. They're like, well, they have to refrain 100%. And what I always kind of come into, because it really helped for me, is sometimes a client can't outright do the exposure 100%, but they can do it in steps. They can work up to it. So if they can't open a door handle with their hand and they have to use their sweater, if they haven't opened a door handle in 3 years, using their sweater is better than nothing. And we can grow from that. So I think that's one thing that I kind of entered with differently. 1226, we have Grace who asks, how do I decipher? I'm going to sum up the question just because it's longer, but Skylar, you can still put it on the screen. But basically, Liz, how can you tell the difference between a high level exposure, something that's high suds, really, really anxiety provoking, that they could benefit in, from something that, hey, a normal person wouldn't even engage in? And then how can they tell the difference? Is this real OCD anxiety, or is this more just normal anxiety that the average person would deal with?
Perfect example, and perfect question. Sorry. So, and I love the example. So I said perfect example is touching dirt for contamination makes sense, right? That's an exposure we would do because guess what? There's going to be times in life where you come into counter with dirt. And if it's something that you're avoiding and something you're triggered by, we need to address it so that it doesn't become something that's triggering or stops you in your tracks later in life. Eating dirt, not really something we need to do, right? That's not necessarily something I'm going to do or need to do. However, if our fear is eating dirt, am I going to tell you to go eat a handful of dirt? No. But am I going to tell you to do something in which your OCD will feel like you've eaten a handful of dirt? Yes. What's the difference? I'm going to have us touch dirt, and then we might go eat a quick snack without washing our hands, or we might go, drink a coffee or do something we enjoy and put our hands to our mouth, because that is something that people without OCD would do, and that you probably will do at some point in your life, right? If I'm triggered by eating dirt or someone eating dirt, I have a 15-month-old. If you think she is not eating dirt unintentionally, we're all lying to ourselves, right? But guess what? The other day I was at a birthday party with her at a park, and I didn't have a sink to wash her hands when she was hungry after she had been playing in the dirt. So yes, she cross-contaminated with dirt. Did I encourage her to eat a fistful of dirt? No. But can I see where if that were an OCD fear, that then I'm not going to let her eat, even though she needs to eat and she's hungry and we're in a park and we don't have another option, that can be disruptive to our life and to our functioning and would go against my values of wanting to be able or needing to be able to feed my kid. So again, think a little bit where this is why, first of all, this is why OCD treatment should be done by trained providers, right? We should know how to target your fears without having to ask you to do something that's dangerous or risky. If someone is asking you to do something that you're not okay with and that you wouldn't do, whether because it's gross, it goes against your morals, etc., you shouldn't be doing it. And that isn't what OCD treatment needs to be. And so I want you to think about that. However, are we going to do stuff that, again, makes OCD think it's maybe dangerous or risky or scary, but it isn't actually? Yeah, we are. Because if we don't, that fear will keep living, and there will come a point where it might impact with your functioning.
Yeah, really, really well said. I'll start with the answer for the next question. You could pile on to 1227 from Elaine. So what is some literature or self-help programs you would suggest for someone who can't find a provider who specializes in OCD? None of the therapists who specialize in OCD accept my insurance. So there's a couple things that I'm going to throw out there. If you go to the iocdf.org website /books, they have a whole section, I'm looking at it right now, under self-help. So there's a whole list of books that can help for self-help. And then when I click on like general, for instance, there is a lot, so there's so many different resources. Also, if you go to OCD uk.org. They also have self-help resources. They mention, because Liz, OCD Challenge is yours, right?
IOCDFs now.
ISCFs, yeah. So
Yeah.
OCD Challenge is definitely there. And last one, I'm there only because I've gone through it myself. I didn't use it for my own treatment. Kim Quinlan is just a friend of mine, and she gave me access so I could look at it, so I would feel more comfortable if I'd refer it or not. A couple years ago, but Kim Quinlan has cbtschool.com, and I'm only recommending that because I've looked through it, so I know. But OCD Challenge is awesome. I know it's helped a lot of people. And go to the IOCDF. I don't know if there's any others that I missed that you'd
No,
recommend.
I think you got it. There's amazing self-help books and resources, but instead of giving my own thoughts, I would recommend you go to IOCDF and find ones that work for you. Because depending on if you're dealing with perfectionism or if you're dealing with certain types, there's books that are specific to that as well.
Sana, I'm sorry if I'm butchering your name, at 1229 says they're from India. So shout out to our international people. I think we always get more international people because Ethan's is always like late at night for them, like in the middle of the morning. So we get everybody. So basically what she talks about is she has to clean a bidet. I believe it's a bidet, like a jet sprays. I'm not fancy enough to have that yet. So she has to clean very nicely to avoid having a stain on my bed sheet after using the washroom. It takes 15 minutes. One of the things that I like to say a lot of times is people will ask me like, Chris, how do I know if something's OCD or not? And I don't, there's a lot of different ways that you can find out. The urgency is a big one, things like that. But one of the ways that used to help me is like if I stood in front of 1,000 people on a podium and said I did something, would everybody nod along, or would it be a special set of rules and circumstances I have to live by simply because I have OCD? And so what it sounds like for you is that this is one of those times that you have to live by a different set of rules because of OCD. So then what we know is it's not really about the washroom and about the cleanliness. It's more about the uncertainty and the distress that you're feeling. And the compulsion is making that go away. It has nothing to do with the washroom because everybody else in your family and friends would do it. So it's more so you have uncertainty, like doubt, disgust, uncomfort. And unfortunately, the only way that you've learned to make that go away is to do the compulsion. So what the treatment's going to teach you instead is there's another way to have that go away. It's by stepping up, getting bigger than the OCD, and powering through. So there's a lot of different ways that you could approach this. It could be potentially like setting a timer for 10 minutes or using less cleaner. So with a provider, it would be coming up with a game plan of how to step down to get to a point that you no longer have any excess compulsions in this process. I'll throw this one out to you. At 1236, I have intrusive thoughts, but I feel obligated to organize. My ordering and arranging is a ritual. Oh, we kind of answered this question, but maybe if you have any final thoughts. We didn't answer it already, but she had said something earlier.
I'll just hop into the answer really quick. I think there is a subtype of OCD that we call just right OCD. So if you're engaging in these behaviors because you love them and you like being neat, maybe it's not as much OCD. But if you're doing it because you feel like you have to, and if you don't, something's going to happen, it could be OCD versus OCPD, for example. But I think if it's like, hey, I just need this a certain way and I like it being a certain way, and if it's not a certain way, it doesn't feel good, that definitely could be OCPD. It's a little bit different because it's not rooted with a fear. So I'll give an example. I like shoes being in the mudroom in a certain place, and I'll come in my house, and if the shoes are like messed up or my daughter has moved them, I will go put them back in their place. Is there any fear that like if I don't do this, something bad's going to happen? No, it's not my OCD, but it is my particularity, if you want to call it that, right? Where I like things to have a place and I feel like, hey, it helps me function better. I'm organized. That would probably be more OCPD tendencies than OCD for me.
Yeah. And a difference for me, like a slight difference, is like my laptop's brand new and I like to keep it clean and case and everything like that. And I'm not triggered if it doesn't happen. It's just very expensive. It costs me a lot of money. I literally use like gift cards from like 10 birthdays for it. So it costs a lot. Whereas like for me, somebody walking around in my house with their shoes on, that's been ingrained. It's something that we don't do in our family. It would trigger me and bother me. So that's, I think, the big difference is like, but I'm far enough in my treatment that if I had to do it, or there's times that I forget something, I have to run in my house. It's not rigid, but that would be the difference. One makes me happy to keep it safe and protected, whereas like somebody walking with shoes, especially many years ago, would have caused distress. Nicole, I think this one comes a lot in families, relationships, etc. I mean, Liz, Nicole's question comes up a lot in families, relationships. So when somebody in the family, in this case, it's her husband, has ADHD, she has OCD, and they clash because ADHD and OCD are on such opposite ends of the spectrum. Any advice on how to kind of engage?
It's so funny because I always talk about the love languages. I don't know if anyone has read that book where it talks about how we all have different love languages. And I'm like, why can we never get paired up with people with the same love languages? Life would be so much easier, right? So like, why, if we like schedules, is our significant other totally spontaneous? But that's life, right? And that's the beauty of relationships and opposites attract and all these other things. And so what I'll say is go with it, right? Life with OCD, or life in general, is about flexibility, right? One of the most important things we can learn is flexibility. Now, if, for example, you're somebody who, for example, like I will put things in our shared calendar and my husband won't see it, and then it causes a problem because I'm on a live stream holding a baby, right? Like we need to have a better communication.
It's almost
plan
like that happened.
Almost, maybe not, right? But we probably need a better communication plan because it's actually like, okay, this is disruptive if I don't get this going. But if it's truly just for OCD, like, someone wakes up in the morning, they want to do something, and for you that's triggering because it wasn't in the schedule. And if it's not in the schedule, something could go wrong. Maybe practice flexibility and see, are there things that you could start with saying, I'm willing to be more flexible during these times, versus things that like, no, we can't be as flexible during that, or we need to be more rigid for certain reasons that actually make sense, not for OCD or anxiety. Yeah, also, I don't know that schedules and plans are always OCD. So I do want to say that too, that like, again, this is where it's like, does it feel like OCD because it feels rigid to us, but maybe it's more of our personality and who we are. And like, that's how we enjoy and how we function. And if that's the case, it's about finding the happy median and it not being disruptive to others, but it might not be something you have to totally address, right? So I like schedules. I like planning. I am not going to work on that in ERP to make it where I don't like schedules and planning, because my life would be in shambles because I have to follow a schedule, right, to stay on track.
I was just going to add quickly, I work with a couple where one has ADHD and one has OCD, and they drive each other crazy for this very reason. And one of the things is like, obviously the person with OCD is working with a therapist, the person with ADHD is working with a therapist, and then I'm working with a couple. And one thing we've been working is each of them, I think a lot of times it's more so that they want to know the other person is trying. So they're coming up with solutions. So with a client with OCD, it's letting some things go, being more flexible. And it's the person with ADHD coming up with different structured things so that they're not always all over the place. So working on that together. At 12:39, Renee asked, my OCD is hovering around my emotions. If I feel sad and then I obsess with feeling depressed and mental checking how my mood is. Any advice on mental compulsion? So it sounds like however Renee's feeling, the OCD then fixates on that feeling and focuses on that. So any advice on those mental compulsions?
Yeah. So remember, mental compulsions are no different than external compulsions, right? They do the same thing in the sense that mental compulsions feed OCD or feed a cycle the same way that external compulsions do. However, in this case, so it's interesting because I do think that there's times where there's really clear OCD mental compulsions that we might want to address with OCD. I'm sorry, good Lord, hello, with ERP. But there's sometimes where intrusive thoughts or things, it's like it may be OCD, but even if it is, we wouldn't really want to do uncertainty for it because it could actually make things worse. And BDD is a good example of this too, right, Chris, where we're not going to do uncertainty statements in ERP where we're going to be like, yeah, my nose probably is distorted and people probably don't like me, because all that's going to do is increase our depression and mood. Yeah. Instead, the treatment is probably going to be more focused on really acknowledging your nose for what it is, right? Maybe you might say something like, oh, my nose is normal and people don't notice it as much. I don't know, Chris, what you would say, but then you live your life, right? And it's about not avoiding anymore and not trying to figure out and solve and be certain that our nose is or isn't a certain way. And I think when it comes to this, of like, if we're finding that we're anxious about being depressed, and so we're constantly checking how our mood is, yes, the reality is that by living our life, we're accepting the uncertainty that we don't know for sure how our mood is, right? We don't know for sure that it's perfect or it's depressed or not. We absolutely have to get rid of the checking. So, that those rituals just keep it bigger. But for this exposure, I actually want the exposure to be more focused on living life. I don't want it to be this long uncertainty script that, like, oh, maybe I am depressed and maybe I'm going to be depressed one day and maybe my life isn't going to be good. Because, like, who wants to think about that? That sounds miserable. So instead, what I would want us to do is go live our life and accept the thought, not accept the thought, allow the thought to be there without trying to solve it. So we have to go to the store. We have this intrusive thought of, what if we're depressed? We need to check our mood and figure it out. Instead, I want us to acknowledge the thought of, like, oh, like, there's the thought, it's there, not try to solve it, not try to suppress it. Instead, allow it to be there and still move forward with our activity.
The only thing I'll add, because you gave such a thorough response, is that what I remind clients is that emotions are temporary. They're a temporary experience in time. Good ones as well, or positive emotions, right? If it's your birthday, you're feeling on top of the world, your friends are all messaging you on social media, you go out to a birthday dinner, in 7 days, you're not going to still be on that same high. That's going to be a temporary experience. And so the OCD is having you fixate at a temporary experience. And by replaying that and fixating on it, now you're just elongating it. So everything Liz said is what to do with that. All right, there's a couple more good ones I'm going to try to get to before we have to end. So Janine DeSimone from New York, she says, my OCD is completely isolated from our family, Chris. So she relates to your story. That was definitely mine for sure for like 3 years. I may miss him desperately, but his anger is actually very threatening. He is 21 years old in therapy, but he keeps looking backwards rather than forward. How can I let him know he has our support, but express that his behavior, regardless of the OCD, is unacceptable? We did a talk many years ago at the conference. It was packed on anger and OCD, and I want us to do a part 2 one year because I think this always comes up. So how does somebody who's already feeling pushed away by their son let them in, but still let them know that the anger and treatment is unacceptable?
Yeah, we actually, Chris and I did a talk on this together, right? But anger and OCD.
Yeah.
So first of all, I want to normalize that when we are feeling overwhelmed and overcome by our OCD, like, of course we're angry and of course we're frustrated, right? So it makes sense. At the same time, as a parent, I want you to have boundaries, and I want you to have keep your child with OCD held to the same rules as people without when it comes to these sort of things, right? So while there's certain things we may flex on for a child with OCD compared to a child that isn't, there's certain household things that aren't acceptable. So an example of this is, I had a parent once that would say things like, well, they always slam their door when they're frustrated with OCD. And I would say, well, would you let your other child slam their door? No. Well, what would happen? Well, they might be grounded, or they might, I'd certainly start with a conversation. Do the same thing for the person with OCD, because you're not helping us by allowing or enabling us to be able to engage in behaviors that are not acceptable. The reality is that the triggers we're experiencing, we might still experience various triggers throughout our life. We can't always get rid of those triggers. But if we're in the workplace and we have a trigger, we have to learn how to tolerate that distress without acting out in a way that's going to get us fired. And so I want you to think too about the long-term impact of allowing behaviors that you wouldn't allow another kid to do. And so I think there's absolutely nothing wrong with you letting them know that I love you, we're here to help you, and we're here to be, as active as we can in your treatment. But here's some ground rules for living in our house or when you're with us. And it includes, right, whether it's no cussing, no slamming doors, no hitting, whatever it might be, those are your rules to decide. But what would you hold another child to? And that child with OCD, in my opinion, should be held to the same thing, because again, we do not want to enable these sort of behaviors.
Last thing I'll add too is make sure if the therapist, if your son is allowing you into the office, let the therapist know. I know for me, if I'm working with a client and the parents or their loved ones report that they're breaking things and very angry, I make sure to address that. Sometimes the good thing is, like with OCD treatment, once the OCD is out of the way and the person has managing tools on the OCD, a lot of times if your son is not an angry person, that kind of goes away. That was my case. I was very angry, but once I had the tools, my anger went away quickly. But I will say, make sure that the therapist is addressing it. Just because we're OCD experts, we've also been trained on how to work with anger and intense emotion. So I make sure to make that part of the treatment. All right, the last one, because I want to make sure to get to it because it's such a good question. So Margie asks at 12:47, do you have any tips for dealing with the uncertainty of a feared event happening in, let's say, 20, 30, or 40 years from now? I'm stuck with this mindset that I feel like I can't enjoy life right now because the feared event might happen at a later date. Thank you in advance.
So remember, right, this is exactly what treatment's all about. It's about us being able to live our life with accepting the fact that we can't know for sure exactly how anything is going to unfold no matter what we do. So you can spend all your days and all your hours trying to make sure that a feared event doesn't happen in 20, 30, or 40 years. And it doesn't matter if you spend 23 out of 24 hours of the day focusing on this, you're not going to have any more certainty around whether or not it's going to happen than you would if you spend 0 hours of that day focusing on it. And that's what treatment's about. Treatment is not about us being able to say for sure nothing's ever going to happen, but it's about us allowing you to be able to live life and not be imprisoned by the thoughts, which is what sounds like is happening right now. And so the best advice is please work with an ERP provider and an ERP specialist so that you can live your life freely versus living a life where you have to be imprisoned by your OCD thoughts.
I'll say quickly, remember that what mental rumination is it's trying to solve a 20-year-old problem that's going to happen in 20 years today. You can't do it. And that's why you're stuck, is because you want to so badly fix a potential problem that's happening in 30 or 40 years, and you can't. It'd be like taking your car into an auto body shop and asking them to fix the bumper. And when they look and don't see a dent, you tell them, oh, in 20 years, I'm sure somebody might hit it. Can you fix it today? It can't happen. So you got to trust future Margie that in 20 years, 30 years, she'll be able to handle it, but there's nothing to do today. A lot of funny comments. A lot of people seem to be dating people with ADHD because they really resonated with that question. So I'm glad we're able to get to it. But yay, we got to it.
I feel a bit exhausted, but we got to a lot. Chris and I still owe you continuing to answer. We still owe you guys a lot of videos where we continue to answer all the other questions that have been pre-submitted. So we will still keep doing that. But more importantly, thank y'all. Thank you for showing up. And I always just want to acknowledge the fact that if you are struggling with OCD right now, being here was a huge commitment and was dedication and is inspiring, because Chris and I both know just how much even showing up from your bed, how difficult that can be. And that is you taking the steps towards freedom. If you're a loved one or a therapist working with those with OCD, please remember and encourage them to always remember that help and hope are always available, and appropriate treatment does exist. Please visit iocdf.org for more resources and support. And Chris, I think we are back in 2 weeks because next week will be the research roundtable. Is that correct?
Yeah, for sure. The 10th. So you'll be back with John and Kyle.
Great. See y'all in a couple of weeks. Bye, guys.
Thanks, everyone who came out.